Hey guys, it's your freaking favorite medical channel, Medicosis Perfectionalis, aka the Rolls Royce of medical education. In previous videos, we have talked about the history of anesthesia and basics and introduction to anesthesia. Now it's time to dig deeper into general anesthetics. Basically, we're trying to knock you unconscious in order to start the operation. We want you to be unconscious and we want you to feel no pain. And while wise people say no pain, no gain, anesthesiologists say no pain, no pain. Question number 1 in the series: why do we give epinephrine with local anesthetics? In the comment section, some people replied with just one reason. I'll give you 5 reasons, baby. We give epinephrine with local anesthetics because epinephrine is a vasoconstrictor. It will decrease absorption of the local anesthetic into the circulation. Okay, local anesthetic will stay here. Oh, where needed. They will not escape to other locations because we constricted the escape path. It keeps the local anesthetic localized. This increases the duration of the local anesthetic in this area. Since you occluded the vessel, you will decrease the systemic toxicity because the local anesthetic will remain local and will not reach the system. Also, when you vasoconstrict, you will bleed less. Amazing. Question number 2. What's the differential diagnosis of wheezing? Not all that shines is gold, and not all that wheezes is asthma. So what is the differential? Asthma, of course, is possible, but it's not the only game in town, not by any stretch of the imagination. Also, you have allergic reactions such as anaphylaxis, mechanical airway obstruction, endotracheal intubation, pneumothorax, pulmonary embolism, CHF, aspiration syndrome, GERD, foreign body inhalation, tuberculosis, organophosphate poisoning, interstitial pulmonary fibrosis, and hypersensitivity pneumonitis. If you want to learn more about pneumothorax, pulmonary embolism, tuberculosis, interstitial fibrosis, and hypersensitivity pneumonitis, check out my playlist called Pulmonology. As we have said before, anesthetic drugs are either general or local. Also, there is regional, but let's keep it simple. General, how do you work? Oh, of course, first of all, I work generally. I want to knock you unconscious, like all of your body. Okay, how do you work? I stimulate GABA. And what does GABA do? GABA is linked to the chloride channel. Oh, like chloride is part of the GABA receptor complex. Awesome. Therefore, when chloride enters, chloride is negative. It makes the inside of the nerve more negative, closer to the resting state and far away from the activation state. This will make you too inactive to the point of being like completely unconscious. And these general anesthetics are divided into inhaled or intravenous. Local anesthetics, on the other hand, are usually inhibitor and blockers of the sodium channels. Sodium, may he rest in peace, was responsible for the depolarization and activation of the neuron. No more. In my physiology playlist, in the video on the action potential, I've told you, whenever potassium is leaving, this is inactivation. Whenever sodium is entering, sodium is positive. The inside of the membrane will become more positive. This is activation. But when chloride enters, the inside of the membrane will become more negative, inactivation. And this is how GABA works, and this is how benzodiazepines and barbiturates work. Oh, they invite chloride into the neuron, making the inside of the neuron more negative, and therefore more inactive. And this is how we knock you out. There is a common misconception that is rampant in the culture. People confuse anesthesia with analgesia. Not the same. Okay, what does anesthesia mean? An means no, right? No what? Aesthesia means sensation, so basically no sensation. This is the literal translation, but not the technical translation. Technically, if we're talking about general anesthesia, we mean this is a state of a medically induced reversible coma. How about analgesia? An means no, and algesia is pain. This is no pain sensation. So let's say I had a headache and I took an ibuprofen, which is a non-steroidal anti-inflammatory medication. Now I feel no pain. What is this? This is analgesia. All right. Do I consider this anesthesia? Oh, shut up. You can still feel heat, cold, vibration, etc. You can still feel the anesthesia is still there. But the algesia is gone. She gone, man. She gone. So technically, analgesia is a subset of anesthesia. That was deep. This is my anesthesiology playlist. Today is video number 3. Please watch the previous videos in order. Anesthesia, general, regional, or local. General, all over your body. I want you unconscious. I want you to feel nothing, not just pain. Analgesia, I want you to feel no pain, no temperature, no pressure, no vibration, no vision, no hearing, no smelling, etc. And muscle paralysis. Why? It's easier for me to intubate you and it makes it easier for the butcher, aka the surgeon, to work, especially in your abdomen, because otherwise, whenever the surgeon touches a muscle, it will twitch and ruin the entire surgery. But my job is not done yet. After the surgeon has completed the surgery, I want to emerge and recover and get back to life. That's why this is a medically induced reversible state of coma. It's not actually coma, it is 5 inches before coma. Then we have regional anesthesia, let's say, okay, the entire lower extremities. Okay, so this is not general, and of course it's not local. Local is very small and general is very big. The regional is in between. And because we have discussed this before, we'll be very quick. Anesthesia, general, regional, or local. General, it's either inhaled or IV. Regional, neuraxial, which means in the axis, in the center of your body, the trunk. Or it could be on the extremities or others. Let me talk about the trunk. Okay, it's either epidural, more superficial, or spinal, more deep. Extremity block is brachial plexus block or lumbosacral block. And this is the most important slide in the entire dadgum lecture. General, inhaled, and intravenous. Okay, inhaled like what? Nitrous oxide, the first to be discovered, and then halothane. Influrane, isoflurane, desflurane, sevoflurane, methoxyflurane, etc. I can't even say it. And intravenous. Intravenous, what are the categories? The isopropofenol, the barbiturates, the benzodiazepines, and the carboxylated imidazole, the alpha-2 agonist, and the phenylcyclidines. Okay, what's the isopropofenol? This is only propofol. What are the barbiturates that can be used as general anesthetics? Thiopental, methohexital. If it ends in tal, it's a barbiturate. Usually, not always. Benzodiazepines, diazepam, midazolam, lorazepam. Midazolam is short-acting, lorazepam is intermediate-acting, but diazepam is long-acting. Next, carboxylated imidazole. This is etomidate, which can intimidate your adrenal gland. Alpha-2 agonist is the dexmedetomide. Phenylcyclidines is the famous ketamine. How about the local anesthetics? They are divided into esters or amide. How do I know if the drug is an ester or an amide? You look at the name. Do you think it sounds like an X? This is a prefix. And then cane, which is the suffix. Or does it look like this? X-I-X, cane. Example, procaine. Oh, that's just a prefix and cane. Prefix, cane. Prefix, cane. But look at this. Prelocaine. Oh, this is a prefix. And this is a connection, and then this is whatever, a root or something, and this is a suffix. Wow, I can't believe I said it right. And then lidocaine, all right, same thing. L, and then I, and then something else, and then cane. Bupivacaine, oh, that's them. So these are the amides, these are the esters. Whether you're going to heaven or hell, you have to memorize these. General anesthetics, what are you trying to do? Reversible, controlled unconsciousness. Coma is too much for me. General anesthetics, amnesia, analgesia, muscle paralysis, and sedation. Stages of the general anesthetic. When I give it to you first, you are analgesic, no pain, and then excited, and then surgical anesthesia, you feel nothing. Not just no pain, no temperature sensation, no vibration, no pressure, etc. And last, this is the medullary depression. Where is the surgeon working? The surgeon is working here. This is the optimum. This is the sweet spot. I gave you a general anesthetic, whether inhaled or intravenous, then analgesia, then excitement, then surgical. The surgeon is working here. If I'm a doofus and I overdid it, oh, that's coma, baby. This is not good. This is the sweet spot. This is the cherry. And then as you wake up, you go in the opposite direction. Surgical anesthesia, excitement, analgesia, and then you wake up and get your sensation back. This is like a country song. Here, you're singing the country song forward. You lose your wife, you lose your house. After the surgery, you sing the country song backwards. Then you get your house back and your wife back. I can't wrap my head around the fact that some people grew up listening to, quote, "She thinks my tractor is sexy." What's the purpose of a general anesthetic? To knock you unconscious. Neuromuscular blocker to paralyze you. Both are needed. Don't forget that the higher the MAC, the lower the potency. When I give you a drug, I want its plasma concentration to hover here. Oh, within the therapeutic window, which means above the minimum effect concentration, but below the maximum toxic concentration. This is the doozy interval. the therapeutic window, which is lethal dose 50 over effective dose 50, if we're talking about animal studies, but toxic dose 50 over effective dose 50, if we're talking about human studies. And we have discussed that before. The higher the blood gas partition coefficient of a freaking anesthetic, the more the anesthetic is dissolved in the blood, which means it will take longer until it works and reaches the brain. A low blood to gas ratio means rapid onset and rapid recovery. Nitrous oxide is the laughing gas. No metabolism. Clinical use after trauma, during tooth extraction, or childbirth. How about the chlorofluorocarbons, halothane and fluorine, isoflurane, desflurane, sevoflurane, methoxyflurane? Don't forget, they can cause malignant hyperthermia. This is not fun. They are pungent and they irritate your respiratory system. Which one is the most likely to irritate my respiratory system? Desflurane. It is a doofus. It is destructively irritant to the lungs, but the least likely is sevoflurane. Sevo makes your lungs smile. What is the solution to this respiratory irritation? Add an opiate. Opiates are very good at inhibiting the lungs. Intravenous general anesthetics are here. Don't forget to prepare the patient. Calm down, patient. Midazolam. A short-acting benzodiazepine. I want to sedate you, patient. Give dexmedetomidine, an alpha-2 agonist. Alpha-2 is anti-sympathetic. This is anti-fight, flight, fright. Give the anti-muscarinic parasympatholytic atropine to dry out the secretions. If you remember my video titled Lactic Acidosis, we have talked about type A, type B, etc. And I've told you about the propofol-related infusion syndrome. What the flip is that? Propofol is the general anesthetic. It's an intravenous one for that matter. When you give propofol, unfortunately, sometimes a syndrome can happen, and this syndrome can cause type B lactic acidosis, which is not fun. As you know, lactic acidosis can cause what? Oh, metabolic acidosis, especially HAGMA. Rhabdomyolysis, renal failure, refractory bradycardia, raised J point, which is on EKG, hyperlipidemia, and arrhythmia. Intravenous general anesthesia, let's go. Propofol, why do we use it? Induction and maintenance of anesthesia. Side effects, propofol infusion syndrome. What's the treatment? Stop the propofol and dialysis because of the kidney failure. The exam question might describe a patient suffering from hyperkalemia and HAGMA after an infusion of a certain drug. The barbiturates, thiopental, methohexital, why do you use them? Induction and maintenance, and they can lower the intracranial pressure. But unfortunately, barbiturates, respiratory depressants. Ketamine, how do you work? I inhibit the NMDA glutamate receptor. This is dissociative anesthesia, which means analgesia plus amnesia. We love to use it in cases of an emergency trauma for induction and maintenance. Side effects, cardiovascular depression, CNS depression, tachycardia, hypertension, increase intracranial pressure. Be very careful if this is a head trauma. Not fun. Vivid dreams, hallucinations, and there is an abuse potential. Absolutely. Etomidate, which intimidates your adrenal. Why does it intimidate my adrenal cortex? Because it inhibits steroidogenesis. We use it in induction, but this is not an analgesic. Side effects, adrenal suppression, and it has cardiovascular effects. The opioids include fentanyl, tapentadol, meperidine. The side effects of opiates are numerous, and they were discussed in my CNS pharmacology course. These are the inhaled general anesthetics in the history of the world, but here, just the ones that we use today. Why don't we use chloroform? It's hepatotoxic, causes respiratory depression and cardiovascular depression. Anesthesia care phases. There's the preoperative phase, intraoperative, and postoperative phase. Preoperative phase, evaluate, choose, pre-medicate. Evaluate, preoperative, evaluation, and then choose which anesthetic are you going to use, and then pre-medicate. Not premeditate, you freaking doofus. You will find lawyers up your pants. Intraoperative phase, you monitor, you access, you plan. You monitor vitals, EKG, oxygen saturation, etc. You access, that's vascular access, and then you plan. General anesthetic or regional, which one will you use? Plan ahead, your induction, your maintenance, and your emergence. Post-operatively, you control, you monitor, you dispose. You control the pain, you monitor, some special monitoring, and you dispose. Dispose the patient to the post-anesthetic care unit or PACU, or ICU, or ward, or step-down unit, or just send him home. Induction is the opposite of recovery. Singing the country song forwards or backwards. I want to induce anesthesia. I have a trauma patient with hypovolemia. Give ketamine, but be careful because it can increase the patient's intracranial pressure. Active bronchospasm patient, ketamine. Be careful, it can raise the intracranial pressure. Patient with risk of nausea and vomiting, probably go with propofol. Beware of the propofol infusion syndrome. Here's the deal, guys. Oxygenation is not the same as ventilation. Oxygenation, if you have watched my pulmonology playlist, there is oxygen in the freaking atmosphere known as FiO2. And then there is oxygen in your alveoli, P big AO2. Then it jumps into the artery, becomes P small AO2. Then it jumps onto the hemoglobin in the arterial blood, and this is called SaO2. S for saturation. How do you measure the oxygen saturation? Pulse oximetry. Even better, get an ABG and send the blood to the lab. This is your ability to oxygenate your blood. However, ventilation is different. Ventilation is your ability to just ventilate your freaking alveolus. And we have two types of ventilation: pulmonary ventilation or minute ventilation and alveolar ventilation. Which one is more accurate? The alveolar ventilation, because it's counting just the ventilation in your alveoli, not the dead space. Do you remember the cardiac output? Yeah, the cardiac output was heart rate times stroke volume. Same exact concept. Respiratory rate times what's the amount of air entering my lung? This is the tidal volume minus the dead space, because the dead space does not participate in gas exchange. Can pulse oximetry assess oxygenation? Yes. Can pulse oximetry assess ventilation? Oh, shut up. Let's talk about malignant hyperthermia. First of all, there is an evil drug known as succinylcholine. Why do you call it evil? Because it can cause succinylcholine apnea or malignant hyperthermia. Let's talk about malignant hyperthermia. Why malignant? Because it's so severe it can kill you. Why hyperthermia? Increased body temperature. When does it happen? Perioperative. Why? Exposure to an inhaled anesthetic or the scummy succinylcholine. What is going on? Hypermetabolic condition. That's why you have fever. Oh, what are the symptoms? You have tachycardia, you have increase in tidal carbon dioxide, and increase the body temperature. So basically everything is going up. It's a triad of tachycardia, increase in tidal carbon dioxide, and hyperthermia. Tachycardia, hypercapnia, hyperthermia. Tachycardia, hypercapnia, hyperthermia. That's malignant hyperthermia thanks to the scummy succinylcholine.
Okay, let's say that my patient has a history of malignant hyperthermia and I would like to prevent this, okay?
All right, give the patient something that does not cause hyperthermia. Avoid the succinylcholine because it's scummy. Succinyl sucks. Instead, you should give the patient a non-triggering agent. Treat the patient as a snowflake. Then be prepared because it can happen, and prepare the malignant hyperthermia cot. Be prepared. As Louis Pasteur has said, for experience, like chance, favors only the mind prepared.
Okay, medicoses, unfortunately malignant hyperthermia took place. What should I do now?
Stop the offending drug. I told you, snowflake. And give dantrolene because it's a muscle relaxant. Because if you leave the muscles to contract, oh baby, the heart will have to increase the heart rate in order to supply the muscles that are contracting like crazy. And when muscles contract, they metabolize stuff. And metabolism secretes carbonic acid and carbon dioxide. Also, it can raise your temperature. So for malignant hyperthermia, don't forget, it is hot and it melts snowflakes. Let's review benzodiazepines because they can be used as intravenous general anesthetics. You cannot understand benzos without understanding the GABA, gamma-aminobutyric acid. Is it a stimulatory or an inhibitory neurotransmitter?
It is an inhibitory neurotransmitter. Okay, if A has GABA and secretes GABA on B, B is going to be inhibited.
But what if A is secreting GABA onto something, and then something is secreting GABA onto B? Oh, double inhibition, disinhibition, hashtag excitation. In other words, if I lose, I can be a loser, but if I lose the loss, I'm a winner. Benzodiazepines and barbiturates, both of them are GABA agonists, and GABA is linked to a chloride channel. When you dish chloride into the neuron, the inside will become more negative, hashtag inactivation, hashtag sedation, hashtag hypnosis. GABA is an inhibitory neurotransmitter. Of course, drugs that are acting on GABA will have the following clinical uses. Of course, if you're an inhibitory, I can use it to sedate you, for hypnosis, I love this word. Anxiety-lytic, no anxiety. Anti-seizure, amnesia, muscle relaxant, anesthesia. What are the drugs that utilize GABA? The benzos, the barbiturates, the non-benzos. Even propofol has some GABA action going, as well as the inhaled general anesthetics. The difference among GABA A, GABA B, and GABA C was discussed in my CNS pharmacology course on my website medicosisperfectionalis.com. GABA A is linked to a chloride channel.
Oh, it's part of the receptor. Got it.
Benzos bind here, barbiturates bind here. Either way, chloride influx will take place, causing hyperpolarization, #inactivation. Benzodiazepines bind GABA A and therefore increase the frequency of chloride channel opening. It opens more, letting more chloride in. More chloride in, the inside of the membrane becomes more negative, hyperpolarization, decreasing action potential, #sedation, #hypnosis. This is GABA without benzodiazepine. This is GABA after you add Look at this. We have increased the frequency of the chloride channel opening. And what the flip is frequency? Frequency is vibrations over time. Oh, you increase the vibrations per second. More openings of the chloride channel per second. More chloride is entering into the neurons. The inside of the membrane is becoming more negative, and therefore you are hyperpolarized. #sedation, #hypnosis. Benzodiazepines side effects. I am not gonna be shocked if the side effects have to do with sedation. Look at this, drowsiness and sedation. Oh, okay, rebound insomnia, motor incoordination, anterograde amnesia, coma, respiratory depression. What's the antidote? Flumazenil. Sudden withdrawal of benzodiazepine can lead to withdrawal seizures. Benzos are anxiolytics and sedatives. Short-acting include midazolam, oxazepam. Just remember the state of Missouri. Think that Missouri has short people. I'm just joking. Okay. Just imagine that Missouri has short people and remember midazolam, oxazepam. Then you have alprazolam, lorazepam, chlordiazepoxide. The long-acting, remember CDC, and the CDC is in Atlanta. So clonazepam, clorazepam, diazepam. I got Georgia on my mind. Whether you're going to heaven or hell, you have to change in Atlanta. And now it's time for barbiturates. Which barbiturates are used in anesthesia? Thiopental, methohexital. If I'm giving you benzodiazepines and I'm increasing the dose of benzo, what's going to happen? So in the beginning, you have paradoxical disinhibition, and then sedation, then hypnosis, and then anesthesia, and then medullary depression. But benzo usually cannot cause coma or death unless you combine benzodiazepine with something like barbiturates or alcohol, because barbiturates and alcohol can take you all the way down to coma and death. What did benzodiazepines do? They increased the frequency of the chloride channel opening more frequently. However, barbiturates will increase the duration, not the frequency, the duration. The chloride channel will remain open longer. And therefore, you can say barbiturate instead of barbiturate to remember that they increase that duration. Barbiturates have many clinical uses. For anesthesia, remember thiopental and methohexital. For severe brain trauma, remember pentobarbital. Benzodiazepines had an antidote called flumazenil, but barbiturates do not. Barbiturates can lead to respiratory depression, CNS depression, even coma and death. They can take it too far. In my physiology playlist on YouTube, we have talked about the sympathetic nervous system. If this is an adrenergic fiber secreting noradrenaline, what's going to happen here? Noradrenaline? Okay, it's being released. #exocytosis. And then norepinephrine is in the synaptic cleft. It can bind to alpha-1, beta-1, or beta-2. But not alpha-2. Where the flip is alpha-2? Alpha-2 here is on the presynaptic fiber. And if you stimulate alpha-2, it will inhibit the release of norepinephrine. In other words, the stimulation of alpha-2 is anti-sympathetic. Alpha-2 is anti-sympathetic. Does anyone remember the mechanism of action of dexmedetomide? Yeah, it was an alpha-2 agonist. It is anti-sympathetic. It is anti-fight, flight, fright. And this is how we knock you unconscious. In order to be a successful doc, you should never forget your ABCs. More on that later. Question of the day. What are the consequences of hypothermia? Let me know the answer in the comment section. You will find the correct answer in the next video. If you like this video, you will adore my antibiotics course on my website medicosisperfectionalis.com. Learn about antibacterials, antifungals, antivirals, and antiparasitic medications. You can also check my CNS pharmacology course to learn about opiates, antipsychotics, etc. Thank you for watching. Please subscribe, join the tribe. You can support me here or here. Go to my website to download my premium courses. Thank you for watching. As always, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.